Morning, everybody. Welcome. My name's Nick Jeffries. I'm the Head of Change for Youth Justice at the Youth Endowment Fund. Really pleased to say that today we're joined by Christa and Deb from Bridgend Youth Justice Service, and an additional and hugely extra shout out that they've actually got their HMRP inspection next week. So kind of to continue and still create the time, I'm sure for any of you that have had the experience of going through any form of inspection, you know, that's a huge thing to do. So just a big thank you for doing that both. Just set a bit of scene setting for this morning's sessions. Unfortunately, we know, you know, violence has a devastating impact on children and families. And for anybody that's worked in the sector, particularly in the space of the youth justice sector, you know that when undertaking or reviewing any assessment, generally what we see is experience of community trauma, experience of home trauma really playing out in terms of children's life journeys into the youth justice system. The Youth Endowment Fund did do a secondary data analysis on adverse and positive childhood experiences and their association with children's involvement in violence. So I'll say check that out on the website, and I'll drop a link in the chat later. That looked at specifically evidence across England and Wales, so kind of a really important piece of work to do that. Deb, you just crossed over to emails as an FYI. That's right. Worth me just iterating, you know, this is an important piece of work for the Youth Endowment Fund. You know, our mission is to prevent children and people becoming involved in violence, and we're currently evaluating several models of trauma-informed practice to see whether those approaches have an impact on crime and violence. Really positive. Bridgend are leading today's sessions with Deb and Christa. I'll come to them in a second to introduce themselves. And they're currently undertaking evaluation with EF on their relationship building together project. This is largely seen sort of practitioners working alongside YGS, their Edge of Care team, youth development and early help services, training on a psychologically led approach underpinned by the trauma recovery framework. Christa, I'll just come over to yourself to do a quick intro.
Good morning, everybody. I'm Christa Bonham-Griffiths, and I am the service manager for Bridgend Youth Justice Service, but also I manage the trauma service across the authority. So yes, that's me. I'll talk to you a little bit about some of my reasons for going for this bid when Deb's had her opportunity to introduce herself.
Good morning, everyone, and thank you for allowing us the time to share our journey with you this morning. As I said, my name is Debbie Jones, and I'm the project manager for the project that we will be speaking about this morning.
Smashing, thanks both. And just to recap in terms of what we'll cover today, so the guys will largely go over the sort of, as Christa said, the sort of background and the sort of sowing the seeds of the project, looking at tiered framework for practice, then moving on to implementation delivery, and then looking at reflections on their leadership, kind of the journey with the partnership and overall delivery, and then looking at sustainability and next steps. And like I said, there'll be opportunity at the end to do some question and answers, and also if there's anything that comes up, I'll monitor the chat. So if there's questions that pop your head throughout, do drop them in the chat. We can pick it up at the end, or I can shout that out to Christa and Deb as we work through. Like I said, I'll just iterate again that we are recording today's session. Generally, we'll try and put these sessions onto the YEF website. Again, just for anybody that wasn't able to join today, and worth me just saying that again that it'll only be speaking to myself that I have the ability to be able to sort of talk and put hands up. But when we get to questions at the end, we'll change that. Deb, Christa, I'll hand over to you both. But yeah, huge thanks, like I said, in the context of inspection next week. And I know you've got huge expertise. So yeah, I know this will be a great session this morning. So just a big thank you from myself, but also to the sector, because I know you've got lots of rich learning to share.
Okay, thank you, Nick. It's a pleasure actually to come and speak about our journey on this trauma project. It's an absolute privilege, to be honest, because I think we didn't think that 2 years ago we would be in a position where we would have extended our trauma work across different departments within Bridgend Authority, but also with some opportunity for extension now over the next 2 years or so. So thanks everybody for coming and listening today. I just want to talk to you a little bit about really just to give you my passion around the work that we are doing with trauma, because for me, as an operational youth justice manager back, 10 years ago or so, when we started to work in partnership with CAMS and the FACS service, and brought in enhanced case management to youth justice services across Wales. For me, it was a light bulb moment when I went into a session for a child who was extensively traumatized, and to listen in to the amount of events that that child had experienced to date in her short life was staggering. And I think before that point where we started to introduce enhanced case management, we were probably touching the surface in terms of our assessment of children's trauma, but to map it and to be able to really think that through and see those children through that trauma lens back 10 years ago was the point where I really felt as an operational manager at that point that we really needed to do more in this space for our children, because ultimately they're our children and deserve to be understood in the way that they present at this particular point in time, because there's always reason and rationale for that. So for me, where we've got to, and with the help of this randomised control trial, has been fantastic, because what it's done is allow us to further our work from youth justice services into prevention services across our authority, and I'll talk to you a little bit about that in a bit, where we really now, I think, are starting to provide trauma responses at that earlier stage, rather than waiting for when children come through the doors of youth justice and already have a criminal incident under their belt. So for me, that was a massive purpose to why we undertook this bid, and then luckily were successful with it, was to try and prevent children getting to that point with more and more violent incidents. So if I just go through with you a bit about the evaluation and research design. Our project, which was called the Relationship Building Together project, is part of a 2-arm randomised control trial, which compares 2 sets really of, and I hate putting children into brackets, but it was comparing a group of children in what we were doing as business as usual in our local authority work already, not decrying that some of that work was very trauma informed, but with a model of practice that combined a framework which and a model of practice that really youth justice were leading on at that particular point. And we took 422 young people aged 10 to 21 across the Bridgend area, and the evaluation measures delinquency, well-being, family relationships, and staff well-being. And that evaluation has been and is still currently ongoing, and it's been carried out by the University of Kent evaluation team, who have applied these different scales to the learning that we are undergoing through this project. Okay. In terms of the background and why relationship building together, around 75% of children involved in our Youth Justice Service or Edge of Care services have experienced trauma or adversity. And traditional responses often were engaging those children too late. So after issues had escalated or exclusions or there was care or offending. And our relationship building together was developed to strengthen early and coordinated trauma-informed responses across services in Bridgend. And the approach aligned with local priorities on prevention, well-being and community safety. Change is not an event, as I say, it's a culture. In terms of the relationship building together project, it's part of the Youth Endowment's national programme on trauma-informed practice, as Nick has already told you. But it's the only project of its kind in Wales, and one of 4 across England and Wales, funded through the trauma-informed systems round. And the project focused on embedding trauma-informed and relationship-based practice within youth justice services, and supports collaboration between youth justice, education, health, facts, and early help to improve the outcomes for children and families. So how that really works in practice is those services form part of our overall trauma service and then work to the same model of practice that is managed by a trauma delivery team. So the consistent practice goes right across those service areas, not just practices within different departments. We aligned that work that we'd learned from the Youth Justice Service, so that we could really take that learning into those earlier help services, and ensure that that consistent model of practice was utilised with every child through the project. What's really important, I think, to outline about that whole coming together for that initial part of the development of the trauma model across the wider prevention services was that we needed buy-in from those partners. And how we gained that buy-in was we introduced them to the multi-agency formulation that the framework offered for children, for them to fully understand before the concept of the project, how understanding that those children's trauma needs right from the outset, from when mum and dad, for example, were living in that home, and then mum's pregnancy with that child, they really needed to understand what we were trying to achieve by them listening in to those extensive trauma events in many cases of those children, and then what we needed to do to try and ensure that they understood the developmental mapping of that child and how trauma had affected that child's development. So it was also about creating partnership relationships, which, from a strategic perspective, by doing numbers of presentations around departments, by speaking to wide-ranging managers around the difference that that could make in terms of people singing off the same hymn sheet, and really understanding children's needs, not just the behaviour that they were responding with and reacting to that. So really those presentations to partners in the early days of the project were really getting them to understand that we needed to move from a reactive position to a more proactive one in our understanding of what we needed to do to respond to those children's behaviours. And that was absolutely crucial, because without your partner's buy-in at the front end, and without the agreement from partners to really achieve from a wider collaborative approach, the struggle is massive. So what I would emphasise right at this point is that collaboration with your partners and the close relationships that professionals build is crucial for that understanding of what you're trying to achieve. In terms of the tiered framework for practice, so if Deb just moves to the next slide, the project was funded by the Youth Endowment Fund. We had 791,000 in total, and 248 to be exact, from the Youth Endowment Fund, with an additional 235,652 in kind support from local partners. And that was from gaining the staff from those additional departments. So those different service areas gave us staff to contribute, because they really saw the benefit of those staff going on to embed trauma practice in a far more framed way within their service areas. So that's where the buy-in from your partners is absolutely crucial. Delivery ran until March 2025, with a sustainability plan built in to local systems and services. And that sustainability plan, I'll talk to you a bit more about in the end, so how we've achieved that, because I think that's probably really useful to know. Trauma-informed practice will continue to be embedded into our own processes within the local authority, within our local authority. So we have signs of safety planning for children within the local authority that children's services are utilising, and we have been working really closely with children's services to embed that practice within their signs of safety framework. We also have embedded therapeutic placement support teams, and we've embedded our trauma practice into some of that therapeutic work that's already ongoing and across our early help pathway. And I think some of that work is absolutely crucial in terms of identifying those children at an earlier point, but also those pathways not being any different for a child hitting an early help pathway to a child hitting a service where there's more complex needs requirements. The long-term goal is to establish a permanent trauma-informed and relational model across the whole of youth and family services. And it's fair to say that we are partway there, and we're getting there, but we're still not quite there yet, and we've still got work to do around developing work even wider into those services. But as probably many of you know, change can take a 5 to 7 year cycle. So, you know, we are only now 2 years through in terms of our development with trauma services across the authority. So why relationship building together? And I'm not going to you know, I'm not going to touch on this too heavily because I'm aware that most people in the room will be aware of why we would think about children needing a trauma framework around them to try and reduce, you know, their offending related behaviour, violence, and improve their well-being. So I'm just going to be brief around these, but we definitely identified a need for trauma practice and a framework to be applied to that practice across youth justice and early help services. And whilst we were aware that people were very much trauma informed, actually applying that trauma work in practice was quite often sketchy. So this project allowed us to really think through how we could really embed a model of practice further into those departments. Bridgend were identified as the pilot site for a UK-wide evaluation funded by the Home Office and Ieuenctid, and that gave us our opportunity. So we aim to reduce violence, exclusions, reoffending by addressing the root causes of behaviour. Universal interventions did seek to do that, which they promoted belonging, emotional regulation and resilience amongst all young people. However, targeting focus on unmet trauma and thinking through developmental needs of children, emotional literacy and pro-social skills, building on strengths of children, was absolutely crucial to embed, we felt. And this integrated response creates safer schools, stronger families, more cohesive communities, and also more collaborative partnerships, I would suggest. In terms of the model of practice, we utilised the trauma recovery model for the core framework for relationship building together. And that model was originally devised by Johnny Matthews and Tricia Skews, who put the model of practice together initially in Hillside Secure Unit in South Wales, because increasingly they were working with children with extensive complexities whose violence was just increasing in the community, and then they were ending up in that secure environment. And traditional practice just wasn't working as well as what they needed it to be. And what they found in Hillside Secure Unit was actually that those children where they really stripped things back to basics and looked at developmental mapping and those children's needs responded in a far better way. It also improved staff sickness, it improved well-being within the unit by working in this particular way. And even though the evaluation was very small in terms of numbers, there were some really positive findings. So we worked closely originally with Johnny and Tricia to help us think through how we could embed this model at that wider prevention level. And the main rationale, I think, for me was around having a framework to pin our trauma-informed knowledge to. The focus on understanding why behaviour occurs rather than simply managing outcomes, and practitioners jointly identifying those needs, strengths and protective factors, to have those combined plans rather than plans that were quite often in silos. So that child may have 5 or 6 plans from different services that may not marry up in terms of the overarching needs that that child may present with. In terms of supporting children and staff, trauma-informed and strengths-based support, as you'll be aware, for young people is vital when you're working within, those services where you are seeing children coming through your doors who have got extensive trauma in the background. So having a framework and a model of practice that allows you to really see that through that trauma lens is vital. Staff have shown great adaptability, creativity and compassion about bringing this model and framework into being within those wider departments. Really importantly, having a model for reflective supervision, peer learning, really does strengthen the confidence of staff working within those environments. So utilising staff with expertise, knowledge to provide those reflective supervision sessions. So we had 4 trauma leads, but we also had psychology input to enable us and therapeutic input to enable us to provide reflective supervision opportunities for those staff members where they were really quite often struggling day to day to deal with those complexities that their caseload could bring, and sometimes struggling to know where to go next. So having those opportunities was crucial as part of that project. A focus on risk management, assistance and family engagement, but applying that trauma lens to that work is crucial also. And I just wanted to just give you a little visual because I think this is really important, that every behaviour is a story waiting to be heard. What we can sometimes see if we don't see the trauma in children, but it does change when we look deeper. So what we then see is children through very different eyes, I think, when we understand and know their story, and when we listen to what happened to that child in more depth, the story for us as practitioners, as professionals, changes. Okay, so let's move on to the meat and bones. So in terms of implementation and delivery, we developed a tiered framework for practice because we recognised that a number of those children coming through those earlier services may not need formulation, as we called it. So they may not need everybody doing a 3-hour formulation if there was just some trauma needs in those children that were not extensive, but they needed to build we needed to build a system where those practitioners, those children were still receiving that trauma support. So tier 1, and maybe Deb can talk a little bit about this because she's got more extensive knowledge than me, but in terms of tier 1, that was for our more universal services where we were identifying children that may have some trauma in the background, but it wasn't as extensive as some of those who were reaching sort of complex service delivery. And then our tier 2 was which was more targeted services, which supported those children at risk through our formulation process and trauma-informed interventions. And our tier 3 was intensive support, which was psychology-led, multi-agency work for complex cases where there was significant trauma for those children. And this structure allowed us to provide the right level of intervention while maintaining shared values and principles. So even though we all worked to the same model, we were still able to structure those cases through where we were identifying children at tier 1, 2 or 3 and what they required at those levels. And it also allowed us to provide those resources, those higher level complex need resources where they were fitting, rather than just apply them to everybody. So Deb, did you want to say a little bit about this?
Yeah, certainly. Thank you, Christa. So how we originally came to place our children in these tiers was when a child came into any of the services, regardless of what service they came from, we would do an initial screening. It was a very simple Microsoft Forms screening form that we designed, and it would just allow the caseworker and the trauma lead to actually see and gather a little bit of information about the background of the child. Was there any ACEs identified? What sort of was the presenting behaviour of the child, and also very importantly, how was mum, dad, carer and other family members, what was their life story as well? So we would gain all that information, and at the end of the screening we would then decide with the case manager, and I think that's very important to say, this was a universal decision that was made. It wasn't just led by the trauma lead, and we would decide then what tiers they would need. And as Christa has said, tier 1 would be sort of general support to the case manager, giving the right resources that may support the child to open up a little bit. So these are the children who did have some emotional vocabulary, but was still had a couple of ACEs in their background. Tier 2 then would be our more serious children, where there was a lot of 4 or more adverse childhood experiences, and they would need the expertise of a trauma lead to support them through a multi-agency timeline meeting. And then the tier 3 was our children who really had a lot of adverse childhood experiences, mum, dad, carer. There have been a lot of experiences negative in their lives as well, and what we would need for them, we would need a psychologist to give more of an analysis in how best to support that child. So we had a very clear structure whenever we started our screening of what we were hoping to get for that child at the end of it, and we did that throughout the project. There was no diversification from whatever service the child came into, so it was a very strict screening right across the board. So thank you, Christa.
So we had a co-design phase from February to June with key partners and service leads. This included our key partners involved in the project, so our early help services, our edge of care service team, who were dealing with children at the point of breakdown, family breakdown, and those children at risk of coming into care, the youth service, and as we sit as part of the education directorate, there was a large number of partners from education as part of this project, and our FACS partnership with our complex care CAMS enhanced case management team. And this co-design phase really was about bringing consistency in the model and thinking through, I think, how we could embed that model as effectively as we could across the different departments. There was quite a bit of work done there, and presentations to Cabinet. There were presentations within departments and presentations operationally as well on the ground to staff in operational teams. There were also a number of weekly meetings that we held with all of our operational staff partners to really unpick how this could work. So we had to really think through how their systems would align to this framework. In terms of the F approval, it was granted in July 2023, and we started then to recruit our team of trauma practitioners. And the psychologist recruitment followed. So the recruitment of the trauma practitioners were that we recruited 4 trauma leads, one for each department. Deb, who was the trauma lead and project manager, combining those roles initially. And then we, in the next phase, we recruited our psychologists. As you can imagine, that was a far more difficult process to really, the recruitment was quite tough in terms of psychology. But what we did there was we contracted existing psychologists to the team, and the full-time psychologist was employed at a slightly later date. We also went to our education psychology department to ask for their support at that point. But as you can imagine, they were inundated with their own work. So initially that was quite a difficult process for us. Rollout began in September 2023. So as you can see, there was not much time between when the grant was approved and the September when we were having to start the randomised control trial. And I'll go on to talk about that a little bit in a short while. It began in September 23 with workforce training that began through the trauma framework model training provider, and we made sure that that was consistent. That training went across the departments, and initially I think we trained 40 staff, wasn't it, Deb?
Yeah, that's
in that
right.
first increment of training. And then we started to practice our initial formulation timelining meetings with the departments, which was quite tough. It was quite a challenge in terms of ensuring that those leads had enough shadowing, knowledge, experience to be able to feel confident to chair those initial formulations. So that's where a lot of work was done initially with the trauma leads. There was continuous feedback. As I've said, we met very regularly, and reflective supervision at that point allowed us to refine delivery and promote consistency across those department areas. It's really important that you provide a framework of support around staff members who are starting quite often something quite new in terms of a framework of delivery, so that they're able to really unpick some of those team-related issues, how they manage different procedures, how they manage staff who perhaps are struggling with the change, and they've got that opportunity to really talk through some of those difficulties they may be experiencing. Crucially, the role of a project manager in this type of project, we felt, was we couldn't have done without it, because you really do need somebody who is going to lead this work and be there to plan, to provide those necessary toolkits that keep us on board in terms of our monitoring, in terms of our day-to-day delivery, in terms of who is achieving what, who is receiving what type of supervision, for example, what the evaluation process looks like, how we evaluate, and just those systems. So the project manager really does act as a bridge between the delivery team and the evaluation partners, and also the bridge for those strategic managers when they're being asked detailed questions over the project, and really provides that organisation that pulls everybody to account. And we needed to ensure that the implementation aligned with both the research standards and what happens in reality operationally. So that was a crucial role, and I know because Deb was the project manager, she'll talk to you a little bit about that in a second. But it's vital that the project manager is trauma trained. It was somebody that we had prior experience of trauma-informed delivery and allowing them to manage both the people and the processes sensitively. Their understanding of the model enabled them to maintain supportive, reflective working environments. And also, I think somebody with a real passion for this work is quite important as well. But this dual expertise in trauma practice and project delivery ensures that we've got that data collection, staff experience and child outcomes remained aligned with the project's overarching aims. So Deb, I don't know if you want to just briefly say something about, because I'm conscious of time, but just say something briefly around how it was crucial for you to be that conduit.
Yeah, I think the role came out, as Christa said, initially we didn't really start with a project manager purely because of timing elements, staff elements, and it was quickly established that there was a gap within the service that we could offer. And I think that what was very important for the role is, having been a case manager myself, I had a good understanding of the additional work that we were asking the case managers to do. So when you work in a trauma-informed way, as I'm sure you all know, that can look very different from handing out worksheets, etc. So I think by having an understanding of the pressure that was put on case managers certainly helped me, and then allowed me to pass that on to more senior managers on the emotional impact that it was having on a lot of staff. So I think, as Christa said, that is a vital, important part on that.
Okay, and there were other crucial project roles that I just wanted to touch on, because when you are setting up a project across the departments, crucially, your strategic managers' buy-in is, it's imperative really that you have that and that they are supporting you each stretch of the way, and that you have aligned managers per department that can really help you to focus this work, because you can't do it alone. Psychology has been absolutely crucial in supporting, as I said, those staff where they really needed to offload some of that caseload trauma. The therapists that we employed, and we didn't employ these therapists until later, and I think on hindsight, we probably would have employed the therapists right from the get-go. So we had a speech and language therapist, and we had art therapy as part of the project, and they were absolutely crucial in terms of offering some tailored intervention support and assessment of some of the children coming through. We've since gone on to even offer more therapeutic interventions. Really important that HR are involved every step of the way in terms of that recruitment of staff, and then contracts, subcontracting, anything to do with staffing. HR are aligned to what you're trying to achieve. Your finance team to assist you with facts, with figures, and how you ensure that your expenditure doesn't go crazy, because really importantly, some of these costs can add up. So really importantly, the finance are on board to keep in line with what you've got in your budget. Lead experts. So, as I've said, I chose to be very involved with the facts team, the trauma team, public Wales trauma team, the TRM management team, the trauma recovery model trauma team, and to ensure that you can discuss your ideas and thinking with experts that have been, involved in this work previously. Operational managers within service areas, and indeed your trauma practitioners on the ground, because as I say, we went on to train extensive amounts of trauma practitioners. The project lead is critical in ensuring the successful delivery of the relationship building together, and they held the responsibility for coordination, maintaining the fidelity to the trauma-informed model, and ensuring clear communication across agencies. Strong understanding of practice enabled them to guide professionals, as Deb's suggested, and it's essential that they had a good understanding of each department's structure and function, so including the departments we worked under, and to bridge the communication gaps and promote integrated planning. And that's vital for the trauma need to have that, or to gain that knowledge with a multi-departmental project, to try and achieve that culture change and promote that sustainable change for the future. Okay, so in terms of our reflections on leadership, partnerships and delivery, I just want to think through some of these things with you. So in terms of our reflections, we had strong engagement from all of the teams really that worked as part of the project. There was really good buy-in, and you could see that buy-in getting better and better as time went by. And actually, that strong engagement is really important to having more positive outcomes for children. The partnership with anybody that is evaluating for you is absolutely crucial. So we met with the University of Kent really regularly, and quite often even some of the language doesn't align. So, in the beginning, some of the language that the university academic language that was being used was going straight over my head. And it's fair to say that I would have to ask the meeting to stop so I could be explained to. But actually, that partnership and understanding of what you're trying to achieve through the evaluation and your understanding of it is crucial, because that allows you to really think through how children are evaluated and how we monitor that practice through the duration of the project. In terms of partnership working, really crucial that if you are undertaking multi-agency timelining or multi-agency trauma meetings, in whatever guise, that you build that shared accountability and that mutual understanding of each other's practice, but actually what you're trying to achieve for that child, and how you can really coordinate your plans together so that child feels at the end of it that people are working with them with a similar outcomes in mind. Senior and operational buy-in ensures that trauma-informed approaches are sustained beyond the project phase, and I think getting our senior buy-in has been absolutely crucial in the move on. I oversaw the strategic coordination, and I delivered across all of the strands of the project in terms of being that project lead, and I was supported by Debbie, and then the University of Kent was led by a professor called Professor Simon Colton, and he provided that evaluation oversight and quality assurance. And I've got to say that the team were very, very helpful. They allowed us to access training courses along the way to understand some of those academic language and the academic vision far more clearly. But the leadership fostered consistency, accountability, and a culture of reflective learning across the agencies, which was crucial. In terms of next steps and sustainability, we have embedded reflective supervision across all teams to support staff well-being and the quality of their practice, and that's been fantastic. I think we've seen some really improved staff and outcomes for children as a result of providing that reflective supervision, because, as we're all aware, staff quite often can be burnt out. They may be struggling, they may be tired in terms of dealing with complex cases. So having that peer organised reflective supervision as well as their manager supervision, and in most complex cases having purchasing psychology supervision is crucial, really. So that supervision model being more embedded is crucial. Development of the ECM and relationship building together champions has ensured continued learning and sustainability. So now we've extended from just the trauma leads to having team champions within service areas, and those champions really do assist in our spreading of that trauma practice even further than where we were. The psychology-led training has strengthened practitioner confidence and the understanding of trauma, and we feel we've improved morale, retention, and shared professional language has been observed across all of our partner agencies, and that we actually talk similarly now about children experiencing trauma, which is fantastic. Staff were randomly allocated to receive the relationship building training to get together training, and then versus a business as usual. That didn't sometimes and didn't always sit well with staff in the beginning, but what I really emphasised to staff was actually you will gain an opportunity outside of this project, because we will have a focus on training the business as usual staff afterward. We are now in the process of doing that in our second phase. So I do feel that we're able now to keep our promise to those staff who operated as the business as usual staff. The trauma-informed training delivered by TRM Academy specialists was delivered consistently, as I said, and across those service areas. And the trauma leads and multi-agency timelining meetings where needed for more complex cases happened across all departments. Some of the challenges that we faced were, as I've alluded to in the beginning, really, that the setup time for planning the project was minimal, and some of that planning overlapped, didn't it, Deb, in terms of when we were starting out the project. So we were still almost refining guidances as the project began. And I think for me, one of our learning and asks really of the Youth Endowment Fund was perhaps to provide more time at the front end for that planning, because that 2-month stretch was gone in an instant, and we probably could have done with a few months more time. Having to produce that guidance as the project rolled out provided us with challenges, because we wanted to get into actually the workings of the project at that point. So, and people were being provided with that guidance that sometimes then changed slightly. So I would have preferred to have had that guidance more set in stone right at the beginning. In terms of staffing pressures, some of the recruitment and retention challenges affected capacity. So the fact that we weren't able to recruit psychologists right at the beginning affected our capacity issue with some of those complex cases, and we had to utilise some of our relationships with other services to enable us to plug some of those gaps. In the middle of this project, actually, we had a restructure, and that caused huge issues for us in terms of some of those practitioners moving and us having to realign some of that work and provide more training, which cost us more money. Access to clinical psychology, and we had lack of in-house provision. So there was a reliance on costly external support. Really important with psychology, I think, to really consider that psychological model and how that's one of the first ducks I would advise to get in a row is your psychology provision, because it is really costly when you have to get commissioned in external support. We had financial constraints and limited resources, which affected our flexibility and our opportunities for further training as the project advanced. The implementation of a new model of practice within children's services also reduced some of our referral mechanisms. That was a struggle, I think, for us. So numbers became an issue when we had the restructure of children being referred in as a result of the departmental changes that went on. So we really had to work hard at our numbers with the existing departments. Moving forward, it's really important that we prioritise and continue to prioritise workforce wellbeing and development, that we explore sustainable models of psychological support, which we're doing now with our education psychology team and our wider FACS service. We are continuing to invest in training. We've had a further grant of money to enable us to invest for a further 6 months in training. But also our local authority has decided to invest in this project for a further 2 years. So it's really exciting for us because we're able to now continue some of that investment into further training, staffing and reflective practice, and build our team wider across our education department with our behavioural and inclusion units. So that's really exciting for us. We continue to build a confident, capable and supported workforce to respond to trauma. And one of the really exciting things that we're doing, I don't know if you would be excited by it, but I am, is that we are developing a sustainable manual for services. So from start of the project, right the way through, going through each element of how we set up a project, right through to all the systems that we use, so that services can have a manual to hand to help them if they are setting up a project of this nature for the future. And I just want to close with saying that our commitment remains to nurture a confident, capable and supported workforce who are competent in delivering positive trauma practice aligned to a framework and guidance that will assist to help children recover from their trauma, feel safe and feel secure. We strive to understand our children's needs to have their voice and feelings heard, promote positive outcomes and their strengths, and help them build better prospects for their futures. So I hope today, if it leaves you with one thing, that this project has a commitment to do that for the future, for the children within Bridgend Authority. So thank you very much for listening. I'm 2 minutes over my hour, I think. So I'll hand back over to Nick to help coordinate any questions you may have.
No, thanks, Christa. They're really helpful kind of overview and sort of reflections on that journey going from kind of the initial formulation, I guess, building on some of the really good work in Wales. You mentioned sort of some of the school units there and the work around enhanced case management, thinking about how you get that partnership buy-in, the early days around, I guess, just shifting thinking, like you said, from that behavioural approach to that more trauma-informed approach. And then also, what does that mean for children? So obviously touching upon the formulation model. I think the bit of for me, the bit of that sort of unique selling point in Bridgend's work is that hasn't been isolated to the Youth Justice Service. That's been something that all of the services, Christa, that you guys have mentioned, being able to access that sort of formulation space that, as you reflected, Christa, has sort of shifted the dial, not just in an isolated youth justice space or adolescent services space. That's enabled that shifting across the board, which I think Christa has contributed to, you know, what you mentioned there at the end, Christa, around ongoing funding from the local authority, which is great news, do you know what I mean, and sort of showing that sort of sustainability of it. So yeah, really helpful reflection in terms of that journey, and that it's an ongoing one, and equally some of the kind of evolution moving from leaning upon clinical psychology support to how you then have evolved that practice to think about how you have trauma leads, but also trying to maintain sort of efficacy to that model. As we said, we'll sort of open up with questions. We know there's always the people busy operation job roles, and we know why we always put an hour and a half for this, try and make sure we're covering off the presentation in an hour, just be mindful that people may be moving on to the next meeting. But just want to open up for any questions. I know there may be some coming in this chat, so I'll just double check that as well. If you are putting your hand up for questions, just please give us a second while we just give you the permission to be able to ask and so on. So just give us a minute or two while we do that. I think Christa, we've got one in the chat, so I'll about to just go for that while people put their hands up. And so we've got one from Lisa, which says, informative presentation, thank you. RCTs are traditionally difficult to apply. How is this managing this project? So Christa, I know you sort of touched upon that, but I know from our convos that there's a huge richness to that journey and a really good way that was framed locally and kind of operationally. So hand over to you both on that one.
Deb, do you want to answer this one about how the randomised control trial was managed?
Yeah, certainly. So it was originally led by Kent, who gave us very clear instructions on how we had to roll out this randomised control trial, because for it to meet all the criteria for it to be a justified trial, then we had, as I say, we had really strict rules that we had to think. So what we actually did, that we sent in all the names of the practitioners across the 4 services to Kent University. And then they just rolled them through the computer. They did everything that they needed to do their end, and they came back to us then with a list of who we could train as trauma-informed practitioners and those who were to remain as business as usual. Now, as Christa alluded to initially, that was very, very difficult, and I suppose we did have a lot of irate staff. I think that was fair to say that, because practitioners felt, especially within the Youth Justice Service, that they were very trauma-informed, which they were. They had already had a number of qualifications that would allow them to work in a trauma-informed way, but unfortunately they had to continue to work what they seen at the time as not offering any trauma-informed practice. But we made it very clear to them that business as usual means exactly as that. And if they were offering trauma-informed practice previously, then that child must not suffer because it's in a randomised control trial. So if they worked with the child and they would change their vocabulary, they would change the way that they worked, then that still had to remain. It was just that it wouldn't be evaluated in with this project. So we had a lot of meetings, and we spent a lot of time individually with case managers actually explaining this to them, that we weren't taking away their practice, we were just not evaluating their practice, which I think was one of the ways that we eventually supported our staff to get through this then.
It's fair to say as well that it was easier within the departments that hadn't worked to this framework before. However, in youth justice, because we'd already applied trauma practice, it was more difficult with our staff group. But I think once we really explained the process, and we also brought the evaluation team in to explain the process to our teams, that was really helpful, because they could see that actually this was part of a process to actually get a better outcome for the future, really, because if this evaluation does prove effective for us, it means that actually we can move this work forward with research that says this is a sustainable model for the future. So it was a means to an end, is what I would suggest there.
Thanks, Christa. And I think on your last point there, Christa, I think equally reflecting in my old role in a youth justice service and having a similar conversations around some YEFNA that we had, that bit of going, it's not that we're taking anything away, it's that we've already got really good response to children. This just gives us an opportunity to test something else out before we go. We're going to completely scale it across our whole service area. It's an opportunity to sort of try before you buy a little bit. And I think like the way you framed that at the end, and certainly from our convos, the way that that helped the team sort of see that actually it was an opportunity to try something different. But equally, we know that we're doing some good work, so we don't want to just overhaul that in its entirety without evaluating first. I'll just come to the next question, which is one from Stacey. It says, unsurprising one here, that police and justice systems aren't necessarily open to seeing behaviour as communication and trauma as a cause. Did you face any challenges here? So okay, now I'll hand over to you guys on that one.
I think initially we did face some challenges here in terms of, and it's fair to say we've, for years being in youth justice, we've faced those challenges in terms of the response rather than looking at the cause and the root causes. And, you know, the whole term consequences of offending, consequences for a child. But I think we have to, and we continue to, try and change that whole outlook, really, by that explanation. Now we've got we've got really good police buy-in, I would suggest, where you know, the police are really changing their mindset to child-first practice, child-centred policing, where the police officer was engaging in formulations, and that when you listen in to children's trauma and what that little life has experienced to date, I would argue it would change anybody's mindset to, you know, that outcome has to be this, and being quite fixed. So I think we've really managed to change mindset by expanding this work into the preventative world, because our prevention partnership model that we operate, where we've got a twice weekly meeting, includes police, it includes community safety, it includes those partners where perhaps that learning is still ongoing for some of those professionals. And having the trauma service there as part of that process has really enabled, I think, the change of that mindset, where you've got those practitioners within that room who are talking through the child with a very different lens.
Can I just add on to that, Christa, as well? I think another good thing that there's been able for police and other partners to see the child through a trauma lens is inviting them along to the multi-agency timelining meetings, because when you have a police officer sitting there and they're seeing what the life that this child was born into, and the developmentally mapping that we do when a child is developmentally age 2, 3, emotionally, socially and cognitively, then it's very, very hard to see that child as a perpetrator then. And very often then they turn around and they see this child as a victim of trauma. And I think that has been a massive step forward for the police.
And Christa, something which we probably didn't have time, unfortunately, to cover today, but through that formulation process and pulling out the really sad sort of journeys of trauma, but by particular sort of trauma points, you tend to build up that map, don't you, where you've got, a vast series of trauma experience, and then the sort of sprinklings of emerging offending behaviour. And I think, again, that can really help turn the dial for that partnership. It's an ongoing thing because, like you said, Christa, people change, but I know we won't have time to touch upon that today, but yeah.
Absolutely. I mean, I just want to touch upon formulation because I think, however many years ago, I feel like a dinosaur in the organisation, but when I first visualised and was in the room as part of a formulation, it was a light bulb moment for me to discover how many trauma events a particular child had gone through just from pregnancy to age 5. And I think when you sit in a room and you uncover that from the information that comes off the police system, from the information that comes off the health system, from the information that comes off social services systems, from the information that comes from a variety of sources, when you see that coming together, it gives you a multiple view of the extensive trauma children have experienced, and you automatically see them, I would suggest, through a different lens. So for me, formulation has been crucial in gaining professionals' understanding of what is that trauma the child has experienced, but also what is it that we're going to do, most importantly, to respond in the best way we can.
Yeah, thanks, Chris. I think really, really important point around the value of formulation, and no doubt through those conversations, I think within the youth justice space, we're really fortunate to often see children at their, at the most vulnerable points and at their best. And I think we always have to acknowledge that often our policing colleagues are sometimes seeing children, when they're presenting with their worst behaviours, and therefore just their line of sight to that child is so different. And I think that's the richness of formulation, is it allows us to all wear a very different pair of glasses and really sometimes reframe the view of that child. Just got a couple further questions, guys, and Jake's also from Youth Endowment team within the evaluation team. Just acknowledge as well that it was a mentally complex trial that really relied on your guys' flexibility and huge amount of work. So yeah, just a huge shout out to that. But the end products, we're going to have some really robust evidence within this area, which is great for something that actually is at the moment such a big part of youth justice practice around preventing children entering the youth justice system. We've had a question from I think it's Sana. Sana, apologies if I'm not pronouncing your name right there. I've dropped in the chat just in reference to our Restorative Justice Toolkit strand, which is recently updated, and then just also our newsletter as well. So hopefully that picks your question up. But if it doesn't, please let us know. And then we've just got one at the end, guys. Probably take this as the last question. Sana, thanks for the message in the chat. Can you share the ethnic breakdown of the 44 children involved in the pilot? I don't know if you'll have that to hand, guys, but probably maybe worth just giving a quick overview in terms of ethnic breakup of the local area, because I appreciate, the makeup of Bridgend is probably going to be different to Cardiff or kind of other areas. But again, I'll hand over to you.
I can give you the answer to that straight away if it permits me, Christa. It was 98% White Welsh and 2% other. I don't like to use that word other, but that's a breakdown. And I think on hindsight of that is something that Kent have had to move forward with as well. Because they didn't realise it was very clinical, and that was one of the issues as well with child's gender as well, that they would only allow us to put male or female, and that was something that we challenged throughout. So that was another difficulty that we fed into, that we didn't have a vast amount of ethnicity, and we weren't allowed to allow our children to identify as they needed to. So I think that was two of the learning curves that we learned as well.
And Deb, just to ask a check-in question, that ethnic breakdown, was that reflective of the local area as well?
Yes, it is. Yes, it is.
Yeah.
And then we just got a comment from Katie, which is just who again is a YEF colleague working on our area leaders programs within the sort of children's services sector for YEF, but having experience in the Youth Justice Service, just reflecting around the formulation model kind of, is quite a common thing, but sometimes delivered in quite an ad hoc sort of way. So again, kind of the opportunity to do that in a framework that's embedded in multi-agency, with a level of consistency, and as Jake quite rightly pointed out, sort of rolling with some of those just operational practical challenges, but trying to maintain sort of efficacy to monitor and double, so the importance of your role within that. And then finally, just coming from Charlotte, which says, can you share the Tracy checklist, please? I don't know whether some of the resources are already on the WAJB resource hub. So again, Christa, Deb, hand over to you guys on that one.
We can share any of the resource kits we're using, and we do plan to share once we finalise the manual, our toolkit for practitioners to look at, to examine and to be able to use going forward, because the hope is from us in Bridgend that people are able to learn from our experience and then take this work forward into their department. So that's the purpose of the manual. But we're happy to share anything that we've built from a Bridgend perspective to assist anybody going forward if they'd like to ask for any of the systems we've devised.
And I think, Nick, as well, is if anybody wanted to see the end of the story with the formulation and a report that is in, we're happy to share that. It's been anonymised. It was a live case, but it's all been anonymised. And I don't know if Christa feels, but I'm more than happy for my email to be shared. And if staff want, if any colleagues want any information at all, they can by all means contact us directly. And I'm happy to share with any information that we have that we're allowed to share.
Just maybe the week after next.
Yes, week after next, please.
Yeah. No, thanks, Deb, Christa. I'm sure that'll be taken up by many colleagues and very much appreciated. Like you said, lots of rich learning. I guess one of the reasons why while this is still going through sort of evaluation, there's just lots of rich learning around the process, around where you guys are now, and like you said, rolling with that change journey. So, Deb, really appreciate the offer. And if colleagues want to take that up, probably come view us in the first instance, and then we can just make sure we're doing that in a coordinated way, like you said, with a busy week ahead next week. Christa, just a huge thank you for your time today. Colleagues that have joined, huge thank you. We have just put an evaluation form in the chat. Being at What Work Centre, we always want to learn, always want to evolve. So please do sort of offer feedback on today's session. But Christa, Deb, thanks for bearing with us. Thanks for continuing. And we planned this prior to that announcement. And yeah, best of luck for next week. Huge thanks for today's session. And yeah, huge thanks for giving up time, colleagues, and look forward to seeing you again soon.
Thank you, Nick, for inviting us. It's
No,
been
pleasure.
great. Thank you. Take care.
Take care. Bye. Bye.